We're fortunate now to have with us Dr. Brigid McCaw from Kaiser Permanente, and she is joining us by Skype. Under the leadership of Dr. McCaw, Kaiser Permanente's Family Violence Prevention Program has done extraordinary work, helping to identify and help victims of domestic violence in California. Victims of domestic violence in the Kaiser Permanente system are much more likely to get the support and services that they need to protect themselves and their children. And her work is considered a model in the United States of America, and as Sue said, it's informed the work that is being done here at the Women's and in Bendigo, and that you'll learn more about later on during the day. So please welcome Brigid from California. She's joining us at a very unsociable time of the night in California, so we very much appreciate that, and hopefully we have her here on Skype. I'm getting nods, so I'm going to hand over to Brigid. Thank you.
Hi, so I'm very delighted to participate in your forum and share some of the learnings that I've gained while working towards transforming the healthcare response to family violence. I think I'll pause for a minute and make sure you're getting good sound. Well, in any case, whether you can see me or not, I am both delighted and honored to be there with you today. And what I'd like to do is share some of the learnings. And so, Stephen, if you don't mind moving to slide number 2, what you should be seeing there is a picture of the systems model, the Kaiser Permanente systems model. So one of our key learnings has been the value of having an innovative approach that goes beyond just the traditional focus on clinician training and instead makes use of the entire healthcare environment and community partnerships. A little bit of background about Kaiser Permanente, largest not-for-profit health plan in the United States. We are located in multiple states, but you're correct. I'm going to be sharing the story from just one of our regions, which is in Northern California. There we take care of 4 million patients, providing the full scope of care. We have a staff that includes about 8,000 doctors, and we have multiple medical centers, and each one includes hospital, outpatient, emergency services, as well as behavioral health services, and then pharmacy and laboratory. Usually this is all in one facility. We also have a fully integrated electronic medical record system, and Kaiser has a very strong commitment to prevention and a mission that includes improving community health. So we're sort of a perfect healthcare system in some ways to try to really take on this difficult task. If you'll move to the next slide, which should be slide number 3, I think one of the reasons that, at least in the United States, there's been a lot of interest in what we're doing is that as our medical centers have implemented the systems model approach, we have seen a steady increase in IPV identification. So this is not the number of women who were screened. This is the number of our members who were identified, men and women, as experiencing IPV. And you can see there's been about an 18-fold increase over the last 15 years. If you move to the next slide, you can see that this shows where the IPV identification took place. So this is by department. Red indicates the emergency department. Green is mental health. Blue is primary care. And so this is the slide maybe that I'm most proud of. You can see the improvement which is occurring in ambulatory care, mental health, and primary care. This means that people are being identified before they present in the most difficult or most urgent or physically problematic situations, and that they're likely being identified in the context of a caring, trusted relationship with a healthcare clinician that they know that can facilitate early identification and intervention that's tailored to the patient's circumstances. In the next slide, which shows that systems model again, what I'm going to do in this presentation is describe these components to you in a little bit more detail, and then talk a little bit about what we've learned about putting this model into place. You can see there are 4 key components: supportive environment, inquiry and referral,
on-site services, and community linkages. And if we move to the next slide, which would be slide number 5, titled Supportive Environment, this describes a little more about what do I mean by supportive environment. And that is information and materials that provide information that are throughout the entire healthcare environment. For example, this poster that you can see is in restrooms as well as exam rooms and waiting areas. And the message here is, let us know, we can help. And we use many formats to communicate about IPV, from the usual posters and brochures to online information, having things included, for instance, in prenatal classes and in ongoing newsletters. This supportive environment also includes an engaged and informed workforce, and that's a topic that I could talk about just by itself. But we know that our own workforce are some of the best ambassadors that we have with our patients, and they both need to know what the resources are and the red flags for IPV, as well as what's available for them and their own family if they're experiencing IPV. The next slide, slide number 6, is just a quick example of what some of the materials look like. And you can see that we try to tailor them for all different groups, whether it's teens or adults, whether it's new moms. And in the next slide, which should be slide number 7, I'd like to point out something that has turned out to be a very important learning. And that is that in order for any screening to take place in a meaningful way, it really does need to be done in a private situation. And that privacy needs to be set up as something that's part of the clinic policy. So this poster, which is displayed in all parts of the waiting rooms and so on, is reinforced by our receptionists, by the person who is helping the patient come to the exam room, and by the clinicians, because we know that if you have some time alone with your provider, there are a variety of different sensitive issues that can come up. So while we often spend quite a bit of time talking about what screening questions to use, how often, where, and how many, this element, which is ensuring that there is in place policies for supportive environment, has turned out to be extremely important. The next slide, which is slide number 8, is about the component of our systems model that has to do with inquiry and referral. There are 2 elements to this. One is from the doctor's point of view, which is the concerns that most clinicians have is, well, how do I ask about IPV? What do I do when the answer is yes? And then, can I offer an intervention that is caring, effective, and also is fitting into a busy clinical practice? And, traditionally the approach has been to develop clinical guidelines and do lecture-based presentations, etc., in the hope that if you increase the knowledge and urgency about a topic, that it will change behavior. We've actually found that it's better to start with figuring out the answers to these questions, putting them in place, and then doing the training. One of the other learnings, however, has also been needing to think about this from the point of view of the patient. Now that seems obvious, but 15 years ago we were just beginning to appreciate how crucial this is. And for intimate partner violence, understanding what affects a patient's decision to disclose and about accepting referrals is really important. You can see on these slides some of the kinds of things that a patient may be thinking about in regard to whether they decide to disclose IPV. The next slide, which is slide number 9, brings us back again to what do we expect clinicians to be able to do? And we decided that it needed to be something that was clear, limited, and it looked like exactly what we do for other medical conditions. And that is essentially ask or diagnose it, affirm and thank the patient for sharing the information with us, assess the acuity of the situation, document, and then make sure that an appropriate referral gets made and a connection to the services that will be most important to this patient. And we've developed clinical tools that support these actions and facilitate making the right thing easier to do. Some of these are embedded in the electronic health record, but they're not limited to those. So the next slide, which is titled Website with Clinical Care Path, is something that doctors can get to right from the electronic health record. But this is something that could be easily built regardless. And you can see it helps guide the clinician with sort of the key things that they need to do. And behind each of these links is the information for both internal and external resources that are location specific. So no matter whether I'm caring for a patient in Sacramento who's going to go stay with her mom in San Jose, it's easy for me to identify what are the resources that she'll want to access in both of those places. And then these are updated on a regular basis. So this is a way of using electronic technology to really support clinicians to do the right thing. Now, the next slide, which says IPV Screening Tool, is another example of one of the ways in which we've tried to facilitate bringing this topic up in the clinical setting. This is a laminated card which is given to the patient by the clinic assistant, after the patient has been roomed. So she has a chance to take a look at it, and then the clinician will review the answers with the patient. Notice here that the text for this card provides some context for why the questions are being asked. Other tools that we have, for instance, the routine GYN patient questionnaire, and also includes IPV questions, particularly ones that are focused on the patient and why they're coming in for a visit. So those questions, while they're also the traditional ones about physical IPV and emotional IPV, include questions about reproductive coercion. For patients, for instance, who are coming in as part of an asthma care management program, there's a question about physical IPV, as well as whether they're experiencing interference from their partner in taking their asthma medicine, purchasing their medicine, or following up with their appointments. So this business of sort of incorporating questions into the clinical setting where the patient is coming and making sure that it's connected to why they're coming in for care has been one of the things we've tried to do. The last example of that, which is on the next slide, which should be slide 12, shows how we've incorporated some questions about relationships into our depression screening tool. And so you can see that what this conveys to the patient as well as to the clinician is that these two things are linked. And we certainly know from the research that they are, that there's a very strong overlap between depression and IPV, as well as with anxiety and PTSD. So this is both a communication and an assessment tool. The next slide is about another key component of the systems model, and this one should say on-site IPV response. Now, this is the what do I do if she says yes? And we've called it the on-site response as it needs to be easy, reliable, and straightforward. This component is going to look different in some settings depending on the ease and availability of social services, mental health, or trained clinician specialists. But this is probably one of the most important first steps in putting an effective approach in place. And it really needs to be figured out before one invests in a lot of clinician training. I've listed on this slide some of the things that an on-site response can include. For instance, triage, danger assessment, starting the safety planning. Now, it's also true that not every clinic, and that's true for our system as well, is going to have 24/7 social services. So having a backup resource is important. One of our backup resources is that our clinics are set up so that a patient can have a private place if they need to contact a domestic violence hotline while they're right there in clinic. If we move to the next slide to look at really the final essential component, but maybe in some ways the most important, and that is the community linkages. Because these are the partnerships which can offer the life-saving, life-changing, practical services that many DV victims and survivors will need to end the violent relationship or to increase their safety if they choose not to leave. Now, this is a broad term. It doesn't include just traditional shelter-based services or criminal justice, but a variety of other resources. And what we're noticing in the United States is that many more of these are available on the internet and via hotline. So I just want to point out that I think the community advocacy groups have really been reinventing their services in many ways, and that we're learning from them how we can better meet the needs of survivors where they are. So what I've done is really talk to you about what is this systems model. And now, if you'll move to the next slide, I'd like to provide a very quick overview of how do you implement this kind of approach in multiple sites and then sustain it over time. So what you see on this slide that says rapidly spreading what works and sustaining it are 5 things that I think have been essential in our work. And, we've gotten some experience now over 15 years, and also from implementing not just in Northern California, but in our other Kaiser regions. And the first bullet, which says infrastructure and sponsorship, is really another way of saying that you really have to have local ownership. And in our facilities, this means a clinician champion, usually a physician, who's paired with a co-lead, often an administrator or a department manager or behavioral health clinician. And they work together to guide the local implementation of the systems model in their facility. So that's usually across a number of departments. They have a team that's usually made up of employees who have a passion and interest in improving IPV, often representing various elements of the healthcare staff, from environmental services to security to medical assistance to the laboratory to behavioral health. And our most effective teams are multidisciplinary and also include the partners from the community who are providing the essential services that I just mentioned. Now, it's important for these teams to have tools, and we don't want folks to have to reinvent the wheel. So, for instance, some of the tools are templates that sort of show what's a best practice for what to do when the answer is yes. What do those referral pathways look like? What do they need to include? It has descriptions of what the various roles are for the implementation team. And also we have ready-to-use clinician and patient education and training materials, so that those things that can be used in common are ready to access for the teams at each facility who need to know how to customize it for the environment that they're in. Quality improvement measures have been absolutely critical. You have to have a way to really measure if you're making progress. And those measures need to make sense clinically and to be locally actionable. So this can't be something that's at a state level or at a large level like that people can't really act on and make changes locally. Now, another whole talk that I could give is about the metrics that we have, because we can use our automated databases to provide information at the facility, clinic, department, and clinician level. We can compare one facility to another and identify where there are best practices. But as you're getting started, I know you don't have an electronic health record at this point, but I would think very carefully about how to choose some ways to measure the progress that can be reported on throughout the entire state. I'm going to say a few words in a moment about stepwise implementation, but the last bullet here is regular communication with teams. And it's been really important to bring the leaders of the teams at the very least together so that they can share promising practices, learn how folks are dealing with challenges, and also which things don't work. So slide 16, which is the next slide, is just a very quick look at what do I mean by stepwise implementation. This is a very intentional steps that we ask our teams to go through so that they start with building an infrastructure that will support their other efforts. So some of these things you'll recognize from what I've said, which is getting a multidisciplinary team, developing a protocol that will help guide what a physician or other clinician should do for patients in both urgent and non-urgent situations, the community resources. The second step is making sure that there are visible patient education materials throughout the entire facility and online where that's appropriate. making sure that the agreements are in place between those departments that are making referrals and those who are accepting them, and then the quality measures. And the next slide shows that step 3 in this stepwise implementation is clinician training. So just to point out again that clinician training is best done, I think, after you can really reliably answer some of those questions about what do I do when the answer is yes. Again, being able to trend progress over time. And then the last step, which is what we've been learning a lot about to sustain the work, is to make sure that the champions and teams do have leadership training and that the work around IPV is linked to other initiatives, whether it's chronic conditions or electronic health record or reducing health disparities, that this doesn't become just a flavor of the year, but something that's value added because it aligns with other activities that your healthcare system is wanting to achieve. You'll notice that at the bottom of both of these slides is stakeholder communications and engagement. And I just want to call out the need for top leaders to be invested in the success of this work and the success of their teams. To ensure that, they really need to be engaged from the beginning. And that's a piece that should not be overlooked. So the last slide is just a picture here again of the systems model to reinforce the value of having a model that helps guide the work over time, over years, that focuses on leveraging the entire healthcare system and community partners, not just doing clinician training and screening tools, and then finally investing in leadership and oversight. So my final slide is I just want, again, to thank you for inviting me. One of the joys of this work is that we're doing it together, and we're learning from each other, and we're learning globally. Australia, and in particular Victoria, has made really important contributions for all of us in the area of research and implementation, the coordination between criminal justice and healthcare organizations. And I appreciate being a chance to be part of your work and look forward to the innovations that you're going to bring to all of us into this effort. So thank you very much.